Assalamu alaikum wa rahmatullahi wa barakatuh. We are going to discuss today wheezy infants and acute bronchiolitis. We are going to discuss the definition, types, and incidence of wheezes in infants, and why are infants more prone to wheezes, causes of wheezes in infants, and the diagnosis and management of acute bronchiolitis. Wheezes is a musical high-pitched sound which is produced mainly during expiration but could occur during inspiration too. It is produced due to fluttering of airway wall, due to airway obstruction and airflow limitation. What is the difference between polyphonic and monophonic wheezes? Polyphonic wheezes, it is a sound with different pitches which is produced due to obstruction in various small airways. These airways has different sizes and different degree of obstruction, so producing finally a sound with different pitches. However, monophonic wheezes, it occur with a single pitch, secondary due to obstruction which occur mainly in larger airways. For example, the right main bronchus is obstructed, producing a single pitch. As you know, wheezing is a common presentation in infants especially, and about 50% of infants below 2 years of age have at least one episode of wheezes. So why are infants more prone to wheezes? They are more prone because of different anatomic factors related to lung and chest wall, in addition to immunological and molecular factors in comparison to older children. Later we are going to discuss two of the most important anatomic factors that can affect infants and make them more prone to wheezes. First, the diameter of airways in infants is much more less than that of adults or older children. And as you know, the resistance is inversely proportional to the radius of the airway to the power of 4. So just small amount of edema will cause large increase in airway resistance. In this figure, you can see an airway of an infant in normal condition that with diameter 4 mm, and an airway of adult in normal condition with larger diameter of 8 mm. We will cause the same amount of edema in both airways, 1 mm edema in infants and 1 mm edema in adult airway. You will notice that there is a much increase in airway resistance in infant due to smaller airway diameter. The airway resistance will increase about 16 times, and the cross-sectional area of the airway will decrease about 75%. However, in adults, due to larger airways, the resistance of the airway will increase just 3 times, and the cross-sectional area of the airway will decrease about 44%. So infants, due to small and narrower airways, are more prone to wheezes. Second, normally under normal condition, there are two forces antagonizing each other. The interaction between the lungs and the thoracic cage determine the changes in lung volume. The lungs have natural tendency to collapse because of their elastic recoil. The natural tendency to collapse and move inward. However, the chest wall has an elastic recoil which tends to pull the thoracic cage outward. These two forces are normally in equilibrium. At equilibrium, the inward elastic recoil of the lung balances the outward elastic recoil of the chest wall. So, the elastic recoil of the lung creates an inward pull, making the lung has a tendency to collapse. This is antagonized by the elastic recoil of the chest wall, which tries to pull the chest wall outward and antagonize the elastic recoil of the lung. But in infants, the chest wall is poorly mineralized, and there is increase in the amount of soft cartilage in the chest wall. So there is increase in chest wall compliance. Compliance means distensibility or stretchability. Increasing the chest wall compliance in infants will offer less resistance to the natural tendency of the lung to collapse. So the highly compliant chest wall will offer less resistance against the natural tendency of the lung to collapse. This makes the infants more prone to wheezes and airway obstruction. Causes of wheezy chest can be classified into acute and chronic or recurrent causes. Acute causes may be due to inflammation, infection, or foreign body aspiration. Inflammation, such as in cases of acute asthma exacerbation, infection in cases of acute bronchitis, acute bronchiolitis, or laryngotracheal bronchitis, in addition to foreign body aspiration as an acute cause of wheezy chest. The chronic or recurrent causes may be classified further into anatomic abnormalities and function abnormalities. Anatomic or structure abnormalities Maybe due to a problem in the airway wall, such as tracheobronchomalacia. There is weakness in the cartilage of the airway wall, making the airway has more tendency to collapse. Or maybe there is external compression on the airway wall, external compression by a vascular ring, by masses or lymph nodes, by cardiomegaly. The dilated chambers of the heart can cause external compression on the airway wall. And maybe secondary to abnormality within the airway, such as tracheal web or tracheal stenosis. Function abnormalities may be due to asthma, gastroesophageal reflux. Gastroesophageal reflux is common in infancy and may be associated with chronic or recurrent respiratory symptoms, including wheezes. This occurs due to microaspiration of tiny refluxed material in the tracheobronchial tree. In addition, the esophageal acid or the acid in the esophagus stimulate the vagally mediated tracheobronchial responses and cause increase in the bronchial hyperresponsiveness to other stimuli. Function abnormalities also include cases with recurrent or chronic aspiration. For example, in a patient with neurologic abnormality such as cerebral palsy, this patient has poor oropharyngeal coordination and has a greater tendency to aspirate. Chronic lung disease has maybe cystic fibrosis, immune deficiency and bronchiectasis, primary ciliary dyskinesia, bronchopulmonary dysplasia. Cystic fibrosis is presented usually with recurrent cough and wheezes, associated frequently with gastrointestinal symptoms in the form of steatorrhea and failure to thrive. Primary ciliary dyskinesia usually presented with neonatal respiratory distress, followed by recurrent cough and wheezes and chronic otitis media. Bronchopulmonary dysplasia, this occurs in preterm infant who was born premature and was subjected to mechanical ventilation and oxygen supplementation for a prolonged period of time. This affects the airway epithelium and may be associated with airway hyperactivity and might predispose the patient later to subsequent asthma diagnosis. Interstitial lung disease is diffuse lung disease. These are diverse group of conditions that mainly involve the distal air spaces, the alveoli, and the perialveolar tissue or the interstitium. So this is a general idea on the causes of wheezy chest. These figures give example about anatomic abnormalities which can cause wheezes in an infant. The picture on the right is a picture of a tracheal web. As you see, there is a tracheal web in the trachea causing partial airflow limitation and airflow obstruction. The second picture is a picture of a vascular ring. Vascular ring is a aortic arch abnormalities which can cause compression on the airways. As you see, the ascending aorta is divided into right-sided aortic arch and left-sided aortic arch. Both of them cause a complete ring surrounding the trachea and the esophagus. So this patient will be presented by a pulmonary manifestation, the form of wheezes and cough, in addition to gastrointestinal manifestation, the form of swallowing difficulties due to the compression on the esophagus too. So how can I approach a case of wheezy child, a wheezy infant? There are some aspects in the history and the physical examination which should be noticed during taking the history from a wheezy child or infant. Initially, the onset. As we discussed previously, if it has a sudden onset, you should suspect and exclude foreign body aspiration. Maybe the onset was gradual following an upper respiratory symptoms or coryzal symptoms. This may occur in cases of viral lower respiratory tract infection or acute bronchiolitis. If the onset is chronic since birth, you should exclude anatomical abnormalities. And of course, the younger the child, the broader the differential diagnosis, highlighting the importance of a higher index of suspicion to exclude anatomic or structural abnormalities. So when the age is much younger, you should exclude anatomic and structural abnormalities in chronic wheezes. You should ask about the pattern of wheezing. Is the wheezing persistent or episodic? Persistent wheezes, this occurs in cases of anatomic and structural abnormalities. There is persistent wheezes not responding to treatment, medical treatment. Episodic wheezes, the patient has interval-free periods, may be improved on salbutamol or bronchodilators, and periods of worsening of symptoms. This occurs in cases of hyperactive airway or asthma. Is the wheezing associated with feeding? To exclude gastroesophageal reflux. In the past history, you should ask about if the wheezing was previously associated with recurrent respiratory illnesses, if the patient has recurrent previous pneumonia, recurrent hospital admission, recurrent otitis media, If there is associated gastrointestinal symptoms such as steatorrhea, as we said, maybe cystic fibrosis, recurrent pulmonary infections and recurrent otitis media, he may have immune deficiency or primary ciliary dyskinesia. You should ask about if the wheezing is occurring in a specific season. For example, wheezing due to acute bronchitis is associated with respiratory syncytial virus in most cases, which occur between October to February. If the patient wheezing is getting better or worsen when the patient changes position, you should suspect vascular ring or anatomic abnormalities. Wheezing secondary to vascular ring usually worsen with neck flexion and get better with neck extension. Family history also should be asked about if there is family history of wheezing, asthma, atopic dermatitis, allergic rhinitis. Neonatal history also should be cleared because, as we described previously, bronchopulmonary dysplasia occur in a preterm baby which was exposed to mechanical ventilation or oxygen supplementation for a prolonged period of time. Finally, the response to treatment will give you a clue about the patient condition. For example, if the patient has intermittent wheezes with interval-free periods who respond to systemic bronchodilator or nebulized bronchodilator, he may have hyperreactive airway or mostly has asthma. In addition to clear history taking, physical examination should be taken adequately. There are some points in the general examination which give you a clue about if the patient has an acute or chronic problem. For example, if the centines of the patient is affected or if the patient has clubbing, these are clues for chronic problem, a chronic respiratory problem which you should search about. So according to signs and symptoms of the patient, you are going to assume a certain diagnosis and do further evaluation for it. If you are suspecting gastroesophageal reflux, you are going to do 24-hour pH monitoring and barium swallow. If the patient has chronic symptoms usually present soon after the neonatal period, chronic symptom of wheezes, stridor, cough, and rattling due to accumulated secretions, you should suspect tracheomalacia, and in these cases, diagnosis can be made by bronchoscopy. And this patient has usually poor response to bronchodilator, and most cases of tracheomalacia, the patients outgrow this condition by the age of 2 years. In cases of asthma, the patient is going to have recurrent episodes of wheezes with intervals-free period and good response to bronchodilator. You are going to be sure by making skin prick test and pulmonary function test and therapeutic trial with bronchodilator. If the characteristics of wheezes or the intensity of wheezes change by changing the patient position, as we said, neck flexion and neck extension, you can suspect vascular ring, especially if associated with gastrointestinal manifestation and swallowing difficulties too. You may suspect a complete ring causing compression on the trachea and the esophagus. In these cases, the diagnosis can be confirmed by bronchoscopy, multi-slice CT, angiography, and barium swallow. In addition, cardiac disease can cause wheezes. As we said, cardiomegaly may cause compression of the airway wall, causing wheezes. Also, pulmonary edema caused by congestive heart failure can cause wheezes by lymphatic and bronchial vessel engorgement that can lead to obstruction and edema of bronchioles. When suspecting cardiac disease, you can be sure by chest X-ray and echocardiography and angiography. In cases of suspecting chronic lung illness, if the patient has a previous history of multiple respiratory illness with failure to thrive, you may suspect primary ciliary dyskinesia or immotile cilia syndrome. These cases, in addition to the chest symptom, there will be recurrent or chronic otitis media, or you may suspect cystic fibrosis. In these cases, the chest symptoms is frequently associated with gastrointestinal symptoms in the form of steatorrhea and failure to thrive. Or you may suspect immune deficiency, especially if there is pulmonary and extrapulmonary affection, if there is recurrent pulmonary infections and also extrapulmonary infection. And you are going to be sure by specific test. In cases of suspected immotile cilia syndrome, you can do bronchial biopsy and ciliary function testing. In cases of suspected cystic fibrosis, you can do sweet chloride test. In cases of immune deficiency, you will measure the immunoglobulin level of the patient. In cases of suspected bronchiolitis, acute bronchiolitis, as we will discuss later, the acute bronchiolitis is mainly a clinical diagnosis. You don't need a further evaluation, you are going just to treat the patient. If there is sudden onset of wheezing and shocking episodes, suspected foreign body aspiration, of course you are going to do bronchoscopy. Let's discuss this case presentation together. This is a 1-year-old infant who is presented with a history of poor growth and chronic cough. At the age of 5 months, he was hospitalized for respiratory distress and was diagnosed as having asthma. He continued to have large, loose, greasy, foul-smelling stool and failure to thrive, despite changing the milk formula several times. Now, by examination, he shows jaundice. Weight is less than the 5th percentile. He is alert and active, but small for age. The head and ENT examination is significant for bilateral otitis media and nasal polyps. Lung showed wheezing and rales, and abdomen is soft, non-tender, with active bowel sounds. So what do you think is the most likely diagnosis? This patient has chronic chest symptoms, chronic cough, and wheezing. He was falsely diagnosed as having asthma at the age of 5 months. But this is not true. Asthma is never associated with failure to thrive. So the patient has chronic cough and chronic chest symptoms associated with gastrointestinal symptoms in the form of steatorrhea, which is described as loose, large, greasy, foul-smelling stool. This is a description of steatorrhea due to fat malabsorption. In addition, the patient has bilateral otitis media, nasal polyps, and failure to thrive. This patient, the most likely diagnosis for this patient is cystic fibrosis. As we said, in cystic fibrosis, there is chronic chest symptoms in addition to steatorrhea and failure to thrive, and nasal polyps also is one of the characteristics of cystic fibrosis. This child is a 2-year-old boy who was playing with his toys and then suddenly began coughing violently for about 1 minute. So here there is sudden onset of cough with witnessed episode of shocking. He subsequently continued to have intermittent episodes of dry cough and was taken to the hospital on the 5th day. On physical examination, he wasn't in any significant respiratory distress, but there was reduced movement and air entry on the right side of the chest, and dullness to percussion also on the same side. So there is localized chest finding here. There is decreased entry on one side and dullness to percussion on the same side. The chest x-ray was normal. So what's your possible diagnosis? The most likely diagnosis here is, of course, foreign body aspiration, and this patient is candidate for bronchoscopy. In this case presentation, there is a 4-month-old male who is presented on the 2nd January with a 3-day history of low-grade fever and runny nose. He has now developed a cough and has some trouble breathing. His immunization is up to date, and he is an only child. He has no known sick contacts, and he attends a daycare center. On physical examination, the temperature was 38.1, the respiratory rate was 60 per minute. He coughs frequently and looks quite ill, and has diffuse expiratory wheezes and mild rhinorrhea. So what do you think about the most likely diagnosis in this case? This is a 4-month-old infant who was presented with coryzal symptoms, followed by cough and increasing respiratory rate. Tachypnea, 60 per minute for 4 months of age. This is tachypnea. So we have here coryzal symptoms for 3 days with low-grade fever, followed by cough and tachypnea or increasing respiratory rate. By examination, he has diffuse expiratory wheezes, and he is coming in a specific season on the 2nd January. In this case, this is mostly especially if the past history is completely free, so this is mostly an acute bronchiolitis case, mostly secondary to respiratory syncytial virus. Acute bronchiolitis is the most common serious respiratory infection of infancy. It has been estimated that about 64 million children suffer from infection each year, of whom 160,000 die. This infection occurs primarily in young infants, most often in age between 2 to 24 months of age, mean age 4 to 6 months. Acute bronchiolitis is a viral lower respiratory tract infection which is caused by respiratory syncytial virus in 80% of cases. The remainder may be caused by parainfluenza virus, rhinovirus, adenovirus, influenza virus, or human metapneumovirus. There is evidence that co-infection with more than one virus may lead to severe illness. Acute bronchiolitis is characterized by obstruction of small airways caused by acute inflammation, edema, and necrosis of epithelial cells, as well as increased mucus production. The diagnosis of acute bronchiolitis is a clinical diagnosis depending on history and physical examination. As was described previously in the previous case, there is a typical history of a young infant who developed chrysal symptoms, upper respiratory tract symptoms in the form of rhinorrhea, sneezing with or without fever, that was followed later on by cough and increased respiratory rate and may prevent the normal feeding of this infant. In preterm and in infant with young age, less than 6 weeks of age, apnea is a serious complication. Examination of this child often reveals tachypnea, tachycardia, fever, retractions. Fine crepitation may occur in 47% of cases, and of course diffuse wheezing. Bronchiolitis, as we said, is a clinical diagnosis. There is no need for investigation. No investigations are needed routinely. There is no needed investigations routinely. As we said, pulse oximetry only should be performed for all those with suspected bronchiolitis, but chest X-ray is not a routine. It may be used in cases of suspected congenital anomaly, or if you are suspecting an alternative diagnosis or a certain complication, or if there is respiratory failure. However, it is not a routine in all cases of acute bronchiolitis. Before managing the child, you should assess for the presence of risk factors of severe disease in this infant. Risk factors of severe illness: if the age of the patient is less than 12 weeks, if there is history of prematurity or low birth weight, or if there is underlying comorbidity, if the patient has underlying cardiopulmonary disease, immune deficiency, chronic lung disease, or neurological disease. These are risk factors of severe disease. The hospital admission is indicated if any of the following are present: if there is signs of moderate to severe respiratory distress, if there is persistent oxygen saturation of less than 90% on room air, so the patient needs oxygen supplementation to keep the saturation above 90%, if there is dehydration or poor fluid intake, if there is history of apnea or cyanosis, if the infant is at high risk for severe illness, as we described previously, or if the family is unable to cope with the child condition. The management of acute bronchiolitis is mainly supportive. Humidified oxygen is going to be delivered via nasal cannula or using a head box, and the concentration required is determined by pulse oximetry. Also, if the infant is unable to take oral feeding, fluids may be needed by a nasogastric tube or intravenous. The updated guidelines of the American Academy of Pediatrics for pediatric bronchiolitis emphasize the use of supportive care only in the management of acute bronchiolitis, including humidified oxygen and hydration. Routine X-ray or laboratory studies are not necessary. Antibiotics are not indicated routinely. Systemic steroid, nebulized hypertonic saline chest physiotherapy shouldn't be administered. And it said that there is no need for a trial dose of bronchodilator. However, other guidelines suggesting trying a dose of bronchodilator. You should assess the patient symptoms and signs clinically and then give him a trial dose of nebulized bronchodilator, then assess him after 10 to 15 minutes. If there is clinical improvement, you can continue using nebulized bronchodilator. If there is no clinical improvement, you should stop using the bronchodilator. As regards the prevention of acute bronchiolitis, respiratory syncytial virus is highly infectious. An infection control measure, especially good hand hygiene, the use of gowns and gloves, have been shown to prevent cross-infection to other infants in the hospital. In addition, bevacizumab, which is a specific monoclonal antibody to RSV, can be given intramuscular at a dose of 15 mg per kg monthly for 5 months to the high-risk group. As regards the prognosis of acute bronchiolitis, most infants recover from acute infection within 2 weeks. However, as many as half will have recurrent episodes of cough and wheezes and may develop hyperreactive airway later on.